Awesome.
I'm so excited. Yeah. Okay, so please meet my American Idol. It's just insane because we have so much in common, and we touched base about 3 weeks ago with an email where I was like, hello, and you were like, hello. And then we were on the phone for like 2.5 hours into the early hours of the morning going, what do you think about this? What do you think about that? So we've got a lot in common, and I hope that tonight you guys are going to get loads of exciting information from across the pond for someone that's as passionate about this as I am. So tell us a bit about yourself before we crack
on. Okay, so first of all, thank you so much, and I couldn't agree more that you're my British idol. So it's such an honor and pleasure to be here. So I'm a small animal surgeon and rehabilitation specialist. I have a practice in Seattle, Washington. So our practice is surgery, and then we have a pretty big rehab and sports medicine component to that. And within those practices, my passion is the kind of bridging the gap between the two, and that's really everything about arthritis. We can do knee surgery, we can do elbow surgery, but ultimately those dogs are going to need long-term arthritis management. So from a clinical standpoint, that's my day-to-day life. My own dogs have been affected by arthritis. You know, I've had Labradors my whole life, and so I know very, very, very personally and firsthand the challenges that owners face with management. And I have the real, pleasure, honor, opportunity to get to talk to a lot of veterinarians around the States and around the world, and a lot of times about pain management, arthritis. And I've realized, over the years, I realized that even though I'd be talking about one specific subject, there were so many things and so many questions that veterinarians had and pet owners have, that I wanted to create something where they could find all this information. And meanwhile, you were doing the same thing. And so
not to the same level.
What's that?
Not to the same level as what you've been doing.
So about a year ago, I had a small group kind of help me put together a website, and it's caninearthritis.org, and that the name of our group is CARE, Canine Arthritis Resources and Education. And we just officially launched the site this summer, and it is just that. It's evidence-based and practical resources, tools, tips for veterinarians and for dog owners managing dogs with arthritis. So yeah, that's me.
Which is awesome, because I was in Colchester, so hi, Blue Bear Rehabilitation. I was there yesterday talking to owners in the morning, and thank you all the guys that turned up, and vets, nurses and therapists in the afternoon, so thank you all that turned up. And there is a massive vacuum of evidence-based medicine kind of understanding online. There's lots of people trying to make money, and there's a lot of people telling you things that you think make sense, and you're like, well, that's kind of ring. Yeah, I could do that. Oh, $200 later. And I think what we connected about so much was that not everybody could afford stem cell, not everybody could afford surgery. There's a lot of people out there that love their dogs as much as you loved yours and I loved mine, and we should still be giving them the tools to do a good job too.
Absolutely.
And I think that's what is really important. And what also owners don't realize is the evidence base that supports interventions, supports those conservative approaches more than anything else. So the weight control, the lifestyle adaptation, exercise modification, we know this works compared to anything else. So we need to get that information out there. So yeah, it's going to be good. So let's start on a really kind of let's go technical first, because we're going to blow the socks off with your knowledge base. Let's go into the intra-articular world. It's something that I've only just started playing with in the last few years. So I've moved from down south up to Scotland so that I can actually work with stem cells. So I'm still very new to it. So we do stem cells, we do PRP, we can put HA, hyaluronic acid in. You've been doing it for a while. So what's your thought? How's your approach? What kind of cases can you tell us about?
Yeah, so, I guess when we look at the human side of OA management, they are pretty quickly to start injecting, steroids or HA into the knee. And that's a pretty common treatment, and with some pretty decent evidence in the human world. And in dogs and horses, probably as much as dogs, people have been looking at steroids and HA, or using it, I should say, clinically for some time, but there's not a lot of research to support those two particular products. Well, there's some. If we start with HA, or hyaluronic acid, hyaluronic acid is a normal component of joint fluid. It's a normal component of the articular cartilage. But in OA, that HA molecule becomes smaller and it's less effective. And the job of HA or hyaluronic acid in normal joints is to give a cushion and viscosity to the joint fluid. So OA sets in, it's a less effective molecule. So we can give supplemental HA, and that can help the body actually produce better versions of its own HA. And so that improves the lubrication of the joint. In terms of evidence-based, there are some studies in dogs that do support its use. There's a lot of studies actually out there, and one of the problems is that they use different products, and there's low molecular weight and high molecular weight. Really, the most recent study that I saw compared high molecular weight to low molecular weight, and both were effective, but we do think that the high molecular weight is more effective. So that's up to the veterinarian to find that product, and there's probably going to be differences between countries in terms of which product you're using. From a cost standpoint, HA and steroids are going to be the least expensive method.
Can you put them in together? So you can use the anti-inflammatory component of the HA and of the steroid, and then you put the HA to kind of like create the bounce back.
Exactly.
And for all you viewers that are kind of going, what are they talking about? I can demonstrate this very well. When you take joint fluid out of a healthy joint, when you part your fingers, it goes boing, and there's this long tentacle of boing. And that means that when you put impact forces through that joint, it goes boing. But when you've got an arthritic joint, you take the fluid out, it goes, and there's nothing. It's just like water. It's just got none of that kind of like bounciness in it. So what Kristin is saying is that you can put an artificial kind of bounce back into the joints. And you can combine that with steroid, which is a potent anti-inflammatory. But how long of time does that buy you?
Yeah, and that's where we really don't know. That's where any of the products that we talk about, we really don't know. In my opinion, at least in clinical practice, what I set owners up for is we may need to re-inject in 6 months to 12 months. And that's usually what I find. The one thing I will point out with steroids is that it is important which steroid you use, because some steroids are actually toxic to the joint. So there's been quite a bit of research out of one of the universities in the US, and they've come out with really saying that triamcinolone, which is, one of the longer acting steroids, that's the most effective one to give into the joint. So for me personally, if I'm doing an intra-articular HA and steroid, that's the combination that I'm using.
Yeah.
These days,
been around quite a while in the horse one, isn't it? Triamcinolone.
Yeah. And again, there's going to be different brand names. There's a human version as well, and there's a different potency between the human and the veterinary versions.
Okay. Can I just tangent really, really quickly, because we're talking about steroids. Do you ever go for depot in palliative care situations? Because I know that floats. A lot of people talk about it, and it is something that a lot of first opinion practitioners readily have to hand. So I would say out of all the practices I work at, none of them would have triamcinolone, but many of them would have depot. What's your feelings on that?
In terms of using depot as intra-articular?
Yeah, as a palliative.
Palliative. Sure. If we're just palliative, I would use it. Yeah, if you're just looking for something and it's end stage, there's not much cartilage left, and we're just trying to protect the, decrease inflammation, sure. And I have in the past, before we had the research to say triamcinolone was the right one. Yeah. The
only reason I say that is I know a lot of vets follow us, and there's a lot of vets that are trying to improve their skill base, and they'll go back to work, and they're going to be infused, and they're going to go, okay, Mrs. Smith's got Roger, the overweight spaniel. I'm just making this up as I go along. And he's got really short elbows, and they hardly move. And, this is like a bit of a life or death situation. Yeah. That kind of thing you do consider as acceptable.
Yeah, I would, especially if we're talking palliative. And that's really where I currently reach for steroids and HA is end stage OA. So more often now I am doing cells, so typically PRP or stem cells. And so you're ready to segue into that?
Let's go. Let's
do
it.
Okay. So, when stem cell therapy first came out, I started doing stem cells probably 12 or 13 years ago, and it was really kind of first launched in the US, and there was a company in the States that had been doing it in horses for a couple years, and then they wanted to start getting into small animals. And so I think the first important thing to point out is that there's a misconception for stem cell therapy that we're going to regrow the cartilage and we're going to grow a new joint or we're going to grow a new ligament. And so far, there's no studies or, nothing to support that. The companies will even say that. But what we find is that giving these cells do change the environment of the joint. And what we see is actually pain relief. And so the fancy word that we use now to say how stem cells or PRP, platelet-rich plasma, what they're doing is immunomodulation. And what that means is the immune system is involved in OA. And there's a lot of different cells that are involved. If we give these stem cells or PRP, we can change the process that the body is naturally doing, and in the end have pain relief. Yeah. So stem cells, a true stem cell is capable of dividing and differentiating into different types of other cells or eventually growing different organs. We're not really doing that. They are able to kind of talk to the cells around them and do that immunomodulation thing. So
and Andy gave me a really good, he was like they're telephonists. They're like the old-fashioned Second World War kind of ears, and they're changing the plugs and they're moving things around, going, right, you over there, you do this and you do that and you wake up. You were supposed to do that a week ago, and they're just they kind of get it going again.
Yeah. And so we can get stem cells from either bone marrow or fat, and we call that adipose tissue is fat, so adipose derived or bone marrow derived. And then there's a little controversy is not the right word, but at least in the States, there's some regulation coming out on what you can do on the human side of once you take those cells out. And in people, you can't manipulate those cells any further. So if you do a bone marrow aspirate, you can give those cells right back to the person, but you can't manipulate them. And when I say manipulate, what that means is if you take the stem cells from the fat, or you collect fat, you collect bone marrow, you can literally take those stem cells, put them in little petri discs, and grow more and more and more and more and more stem cells. And that's what many people think, or maybe the right thing is to give all of these stem cells. We don't know how many you need, true stem cells. But by doing that manipulation on the human side, that's frowned upon. It's not allowed. And so because of that, we have techniques that we are just kind of taking what you get what you take out, process it just bench side. So you spin it down in a centrifuge, remove the stuff you don't want, and then give it back. And so,
but that's creating a bit of a problem, because when people talk about stem cells, be it vet to owner or vet to vet or vets to trying to read about stem cells, is there's a massive difference between different stem cell providers.
Yes.
Where I'm working in the UK, we are allowed to culture. We do use fat. It does go away to a lab. And we are culturing and we do not inject anything less than, I think it's 2.5 million cells per mil per joint, so we have this very strict rule, and quite often it might be up to 7-8 million, that we're putting. So we can count and we can check viability as well. So when we get our certificate through, we're like, we know how much we're going to put in and we know how many are alive before we put them in. But there is difficulty because a lot of the research coming out is very split, isn't it? It's people are doing different things, and it's all classified as stem cell.
Exactly. And that is exactly the problem with trying to compare from a research standpoint what's working. We in the States, we are able to culture stem cells for dogs too. So whether it's bone marrow or fat derived, currently the technique that I use and have been using is adipose derived, what we call stromal vascular fraction. So it's the fat goes off to a lab, they remove the stuff we don't want, but they send back stem cells. And sometimes it's about 1 million and sometimes it's not nearly as much. And then there's some other growth factors in there and some other things, the soup that we then inject. What they do is they then save a sample of those original stem cells, and then we can start culturing them for future use. But the problem is we don't have any studies, at least with this technique, to compare what's better, this cultured or the original SVF, stromal vascular fraction. So there's still a lot we need to learn about stem cells, but I will say, and I kind of get reluctant to even say this because there is a big cost associated with stem cells. And it seems like it's this kind of hot topic and sexy term, but I do see results with it. I really do. And the clients come back and they tell me the dogs are doing things that they haven't done in years. I do think there is something to...
Just quickly on that note, I've got to say this. Do you own a stem cell company? Have you got a vested in...
No.
Is there any benefit for you telling the rest of the world that you have had... Can you just declare that this is honest truth for your experience, not because you're trying to...
Right. I have consulted for VetStem, so the stem cell company I use. So I have consulted for them. And the time that I consulted, I was paid for the time that I gave to them, but I have no vested interest beyond that. Yeah.
And I work using stem cells, but I gain nothing about talking about it.
Yeah.
For me, the most important thing about CAM is that we get evidence-based first and an opinion and like a personal testimonial of having used it for a period of time. So I think that's very, very valid. And I think it's an exciting field. But moving on from that, because you're right, it's expensive. It's really expensive. Let's downgrade and talk about PRP, because that is slightly more affordable. And we're going from thousands to hundreds.
Yeah, absolutely.
We've got a similar problem with PRP, though, haven't we? In that people are doing different PRP work and they've got different quality PRP that they're injecting.
Yeah. Yeah, so platelet-rich plasma, I think just the problem starts with just what the definition is. So you say the word rich, and that implies that you have more platelets than you did in the original blood sample. And so just to explain what we do here is you draw blood, and depending on which machine and which company you're using, the amount of blood can vary from anywhere from 12 milliliters, so just a small amount of blood, to a big, huge vial, 60 milliliters of blood. And then you spin it down right in the hospital and collect out the platelets. And platelets, what they are normal blood cells, and they are the first little cells that go to an area of injury and they form a clot. So platelets are what form a clot. As they clot, they release all of these growth factors, and the growth factors are what are going to help stimulate healing, but not so much curative intent with OA. But they're going to do similar to what the stem cells were doing, is where they're changing that environment and decreasing inflammation by a lot of mechanisms we still don't understand. So it's an easy process. All it is a blood draw, rather than a bone marrow or a surgery to get fat. So blood draw, isolate the platelets. But now that's when we talk about the platelet rich, the specific machine or type of company use that you're using, it's going to give you anywhere from the same number of platelets that were in the original blood plus or minus red blood cells and white blood cells, or 3 times, 5 times, 7 times, really truly concentrating the platelets. And I was just reading a human journal article on this, and they're saying that in order to truly be considered platelet-rich plasma, it has to be 5 times the number of platelets. I don't know that in the veterinary world we have that number established at all. What we definitely know is that if we take 5 different PRP companies, we're going to get 5 completely different products back. Yes.
And that's the thing, is that when I have Holly's Army people talking to each other, so Holly's Army is this lovely community group, you're welcome to join, just find us on Facebook. And people around the UK, around the world, are talking about these interventions, and it's very difficult for us to say, yes, give it a go, because I don't know what the vets that they're going to will use. And, you know, it's still a very emerging field, and that vet with the best intention will be giving that owner what they think that owner wants and has read about, and it could be a really inferior product, which is it's very difficult.
Yeah. So there there are 3 products in the States that have some evidence behind it, some research behind it. They're not huge studies, but they do have some pretty good research behind it. And those are the ones that I personally use, but I will say we do seem to see results, but I think that there's still a lot more research that's needed there in comparing different products.
Do you have any vested interest in mentioning their names?
No, I consult for one of them. I won't even mention the name because I don't even think it's available over there. I do consult for one of the products, but I don't get any sort of royalties or kickback or anything.
So that's fair. We've got lots of vets that are watching us, so I don't feel uncomfortable. Who would you be recommending then? Who's got a good product and a good support system? Because I think that's really important too.
Yeah, so I'm using Owl Manor, and it's actually a product that's called ProStride, and it's been used in horses. Again, a lot of the interventional therapy I think we take from the equine side, and then learn a bit more in dogs. So Owl Manor and ProStride, that's the one that I'm using right now. We also do use Arthritis ACP that has a little bit of research behind it, and the VetStem VPAL system, which I have, but I don't really use very often.
Yeah, so we're using the companion CRT, and I have no vested interest. That's just what we're doing, and we're happy. So what we do is we're taking a 60 ml, but we take a small amount before, and we do a hematology on it, and then once we've processed it, we do another in-house hematology and check. The platelet count is doing what it is, and it isn't got red blood cells and white blood cells in it. So we kind of do our own in-house quality control to make sure.
That's awesome.
Cool. Okay, so
that's great.
So we've done stem cells, we've done PRP. We actually do quite a lot of stem cells plus PRP. Is that? Yeah, cool.
Yeah. I mean, I think there's definitely a synergistic or an additive effect using them together.
Cool. Okay. Now you are going to now talk about some things that I get really excited about, because when you emailed me, I think it was yesterday or today, and said about radioactive tin, I went, oh, you know? How do you know? So one of my kind of like OA gods from about 3 years ago is a guy called Stephen Fox, and he's written that it's a hardback, it's A4, a textbook, and it's the multimodal management of OA. And when I did like searches for learn a beginner guide to OA, I was kind of like, this is the only book that I found that had any kind of, it was in between being hardcore and being noddy. And I was like, cool, I'm going to read that. And he talked about it in there at the back. So I emailed him and said, look, I'd really like to know more. And he sent me the company's work. And I've asked so many people, and no one knows anything about it. So have you experienced it?
Well, I don't have clinical experience. I'll tell you my story. So Steve Fox is also an idol of mine in the OA world. And I was giving a presentation on multimodal management of OA about, 3 or 4 years ago. And Steve Fox stands up in the audience and asks me, do I know anything about radiosynovial orthosis? I can't even say the word, radiosynovial orthosis. And I had never heard that word before. And he put me on the spot, and I was like, I don't know anything. And so he educated me and the audience on, it was the first time I'd heard about it. Since then, I have had the opportunity.
Oh my God, that would just scare the hell out of me.
I know. I mean, I've known Steve Fox for a while now, and thankfully I had, I knew who he was, and we had a relationship, and that was fine. I love learning from him. But yeah, so now I'm actually on the advisory board for that company too, and have been working, just trying to learn as much as I can from that. And so what it is this radiosynovial orthosis, RSO, is a technique where there is a radioisotope injected or used for a therapeutic purpose. And it's actually been done since the 1960s in Germany and Europe, using a different, not the tin, but 2 or 3 different radioisotopes. And what happens is you inject this radioisotope, and it releases this kind of energy, and it can essentially kill the cells around it and decrease pain. And so they've actually looked at these things for metastatic bone cancer and managing that type of pain, and now looking very, very closely at arthritis. And so the product that is coming out, so it's radioactive tin, it's tin 117M is the actual molecule,
Yeah.
In the States, the brand name is called Synovitin, and it is commercially available in the state of Texas right now.
Oh, okay.
So in order to get it, they're understandably, so it's a radioactive material. So you have to have a radioactive material license for your practice and as an individual. And so there's a regulatory council in the country, in the States, that has to tell each state kind of what to do now with this new product. And Texas was the first state that they kind of really figured out what's happening. It's also where there's a very big practice there called Gulf Coast, where they did some of the research in dogs. So LSU, Louisiana State University, Missouri State, or University of Missouri, and then Gulf Coast.
Yeah.
They've treated, including the clinical trial dogs and preclinical trial dogs, there's about 100 dogs that have been treated with the Synovitin. And what they're finding is very good success rate. So anywhere between 60 and 80% success measured with force plate. So that's where the dogs have to walk over a platform, and it measures how much pressure is put through their feet. Yeah. And the CBPI, the Canine Brief Pain Inventory. Yeah. So both objective and more subjective owner data. So anywhere from 60 to 88% success, and that success is lasting out in many dogs up to a year, which is, number one, it's the first type of product that we have data that follows dogs out that long. So, you know, we talked about all of those other products. None of those other products have data for a year, and this one does. So it's very exciting from the evidence-based standpoint, the research that's gone into it. A lot of the reason that there is so much excitement and research going on is that it is also in development for humans. So there's a human counterpart looking at it for OA.
Okay.
So I'm excited to use it. I'm in the process of trying to get that radioactive materials license, and it's a lot of hoops to jump through. You know, when you hear radioactive material, my first thought was like, well, what owner is going to want to do that? Give a radioactive material to their animal. But the benefit of this particular tin is it's very safe. So the way that it works,
a radiation field of like 2 millimeters, and it's gone in 14 days, doesn't it? It's short. Yeah,
exactly. Yeah. So what happens is you put it directly into the joint, and it is the exact right size that the cells called macrophages and activated synoviocytes. Those are both the main cells involved in inflammation inside the lining of the joint, called the synovium. So those cells basically they engulf the little tin molecule, and it causes them to die. It's a process called apoptosis. So it doesn't create additional inflammation. And so by getting rid of those inflammatory cells, it essentially decreases the inflammation in the joint by a completely novel mechanism compared to anything else we have.
And it kind of stops the cascade as well. And I think that's what a lot of people don't realize, is that it's not just arthritis inflammation. It's like and it kind of just spirals and spirals and spirals. Whereas this kind of goes, poof, you're overdone with.
Yeah. Yeah. So it's
very exciting.
Yeah.
And I'm so pleased that you know about it, because I can remember posing the question. So I've got to let Luna in. 2 seconds. Luna, come on in. Sorry, I'm trying to work. And the dog's whining. I mentioned it to a few people a couple of years back, and no one heard about it. So I'm really excited about that. But that's not going to apply to a number of our owners, like 99.9999% of our owners.
And it's not going to be an inexpensive treatment either.
No. It's going to be. Let's do the other couple of things that I know nothing about that you mentioned in your email. So botulin, and then there was another toxin.
Yeah.
I'm really excited about this. I worked with a lady that had a really, really bad neck problem, nerve trapped in a neck type thing. And she battled for years and years with pain management. And she ended up going for a specialist, and she had botulinum toxin injected locally. And the results were insane. She went from walking around work like this all the time.
Yeah.
Like, oh, it works again.
Yeah.
So what's the news about that?
Well, so, you know, Botox, botulism, so in the same way, it basically kind of deadens that muscle contraction locally, so the same way you'd use it for wrinkles. But the idea is giving it intra-articularly into the joint that it decreases the release of neurotransmitters.
Right.
The exact mechanism of action isn't completely understood. There are some studies in dogs that have looked at different indicators of inflammation, and some of them may be decreased and some may not be. But the idea that you're giving this molecule, this toxin, that will kind of stop the release of those inflammatory products. So a number of years ago, I can't remember the date, it was probably 10 years ago, I saw the first study come out, and it was actually a friend of mine and his intern that had published the paper. And as most veterinary studies, it was a low number of dogs, less than 20 or so. And they did see initial improvement, and it was looking at kind of all joints. And then since then, there have been some other studies, only a handful, and it's conflicting evidence. So I was able to find 4 different dog studies, and some of them said it helped, some said it didn't. And there's a lot of unknown of how much, like what the dosing is. Botulism is like the most toxic thing on the planet. So yeah. So making sure that the dose is right is important. And so I think there's work that needs to be done there. Yeah. On the human side, it is, there are some good randomized controlled trials showing that it can be effective. The thing that why I feel like we haven't talked about it, or we don't hear about it much in veterinary medicine, is I don't think that there's a company behind it that's really pushing it. And so that's where we don't get as much of the research from it. I have zero clinical experience with it. To be honest, the idea of handling it scares me. And so I don't have any experience with it.
But the thing is, what's good about doing this chat is that I really want to challenge vets' opinion that arthritis is boring. Okay, so a lot of what we're talking about will probably not be relevant to the owners, but I'm hoping that they'll take excitement that there's changes, there's things there. We are moving in the right direction, and we've got options. And I'm hoping that the veterinary professionals that watch this kind of go, wait, no one told me about this. Because I definitely feel here in the UK, there's a little bit of an apathy to OA in that, well, there's not many treatment options, so it's this and that only. I hope that this section of tonight tells people there's a lot happening, and there's a lot of things out there that is giving people kind of potential in the future. There was another one to talk about, and then I want to talk about the problem that we have with the cases that we manage, which is quite often it's not uni-articulated. We're not dealing with one joint. What's the last toxin, and then we'll change into general.
The last one is resinavaratoxin. So big word. It's so I think the cool thing with all of these novel products is that historically we thought it was all about just prostaglandin E. Like it was just block that one inflammatory molecule and everything's taken care of. And now we're recognizing there's so much more involved in OA and a lot of different targets. And so there's a receptor called the TRPV1 receptor in the membrane, and it has a lot of important roles, but one of them is in transmitting pain. And so this resinavaratoxin is basically like hot chili peppers, and it will bind to that receptor and kill it, and so it doesn't transmit the pain. So it is a product that has some background data in dogs and kind of laboratory dogs, and this is one that I do have experience with. I was part of a clinical trial last year looking at it, and the outcomes, the efficacy was encouraging. I think there's still some work that needs to be done in the development, but it does excite me that there's new novel treatments coming out.
And is that going to be, dare I say, is that going to be affordable? Whereas we're talking about stem cells and PRPs and innovating OA, and you're like, whoa, that is out of reach. Is there any scope that that's going to be affordable?
I honestly don't know. And we would ask the company that, and they just weren't really ready to give that information. The product's also in development for humans too. So it's all of the research that we're doing in dogs is to try and help for human OA and chronic pain as well. if I had to guess, the resinaferatoxin would probably be priced less than stem cells and synovitin, but more than PRP. That would be my guess,
Okay. No,
but I
that's
don't
cool.
know. Mm-hmm.
Well, I think because I don't want too many people that are just doing conservative management of their dogs to sit there going, well, this just doesn't apply to me, and they've spent a whole hour talking about stuff that's not relevant. I think one of the things that is a big problem with the intra-articular approach is when you've got multiple joints. And the work that I'm doing at the moment, we might be injecting 12, 15 joints, because quite often these dogs have got tendinopathies, they've got elbow OA, they've got carpal changes, they've got, phalangeal changes, and you're sitting there going, well, if I help here, then that's going to flag this one up. So trying to work out what is the problematic one. You'd always leave that dog in a month going, well, that's really fine, thanks so much, but this really hurts.
Yeah.
So how do you choose when you're going to do intra-articular, I guess?
Yeah. So I choose, intra-articular tends to be kind of my second tier of treatment. Always, I'm going to start with, unless I can't use a non-steroidal anti-inflammatory, that's going to be my baseline, because that's going to have the quickest effect. So if I have a headache or if I have a sore muscle, I'm going to take some ibuprofen, and that's going to happen quickly. Also, from a research evidence-based standpoint, there's nothing that has more evidence than our non-steroidal. So pick your favorite one. And then weight loss, weight management, activity modification. Those are going to be the mainstay of my approach. We have other products. I think you guys have Cartrophin, we have Adequan. So that's usually something that I'll use early on in OA management. From a rehab standpoint, definitely if we can get them in, and mostly for me, it's getting them moving. We can do fancy things like laser therapy and pulse electromagnetic field. I think there's something to those, but I think exercising and getting the body moving and getting the muscles stronger is the most important thing. So when those things aren't working and we need something else, that's usually when I move to intra-articular. And of all the joints, I think the elbows are the toughest to manage. So I probably inject a lot more elbows than I do hips or knees or anything else. So we're going to those a little bit sooner. For me, because I'm in a referral practice similar to you, I think at this point, I see patients that have already often tried some of the other stuff. And usually I'll do the rehab bit, but they may be more chronic and more involved and a little bit older. And so we'll go a little bit sooner to the intra-articular. But I don't think it's the foundation of any of our treatment, for exactly the reason that you said, is that, we can make that one joint feel better. But if this OA has been going on for any period of time, there are changes in that whole nervous system up at the level of the spinal cord and the muscles that surround it. And to just think that we can inject something and be done is completely false. That actually is one of my criticisms.
Can we just a little pause there, because you've said something so important, that every single owner of an OA dog understands whether you can afford top of the range stem cell synovitin OA when it comes out, you are still required to do rehab, because you're getting a window of chance, a window of opportunity. In that, Kristin really rightly said, it bought a year. But in that year, you can get the weight off, you can change your lifestyle, you can get some stamina back into that tissue, and it can last longer. But when people have the attitude that, well, I've had this done and it costs a lot of money and it's fixed, no, it doesn't. Nothing that we do is ever going to fix it. So hopefully the people that can't afford the synovitin OA, the stem cell, all of these sort of things, can still go, well, this still applies to me because I'm doing conservative management. And that's what we do in non-steroidals. We're hoping to buy people a window of opportunity. So we're trying to reduce the pain, the inflammation, and we're trying to give that dog a chance to be more mobile, so that they can employ activities that can improve tissue function, which will provide stability. And if we have stability, we hopefully have less pain. So the principles, the underlying principles of we're buying you a window of chance applies, whether it's a non-steroidal or whether it's a stem cell. Truth, or am I being too simple?
Absolutely. It's yeah, it's just a small piece of the puzzle of treating just at the joint. It's
Yeah.
OA is a whole body disease, a whole body
Yeah.
condition. Yeah, and actually, even when it comes to the research studies for any of the products, none of them are doing rehab after the injections, and so even the ones that I've been involved in, we inject the joint, and then we're literally not allowed to do anything rehab. They have to like all be doing the exact same thing. And just as you point out, if we have an arthritic elbow, there's a really good chance they've got a tendinopathy in their shoulder. And that really should be worked on because that's going to now be a new source of pain and lameness.
Yeah.
So yeah, the activity, the fundamental parts of managing OA, weight management and activity modification and non-steroidals, I think that is the foundation everybody needs to be doing.
Let's play with non-steroidals for a bit, because I think it will be really good for CAM followers to hear this, because especially on Holly's Army, we have people that arrive and they say, hey, I'm Claire and this is my dog Rufus, and I want to find things alternative to non-steroidals because I hear that they cause liver and kidney damage and dogs die. And you're like, oh, please, please don't arrive with such a negative spin on something that's going to buy you chance. And
yeah,
I'm quite blunt about this, is that we know as a veterinary profession and as owners, we're quite poor at detecting pain. We're quite poor at quantifying pain. So as an owner or a vet, when you do believe pain is there, that it can be pretty bad by this point. So if I was in pretty bad pain, I don't want the caregiver for me saying, well, let's just try this and see when it works, if it works. I would rather my caregiver said, I'm going to give you something that works really quickly, really effectively, and hopefully that gives us a window of opportunity to introduce other things that we think might be effective.
Yeah.
I just really wish that owners didn't have such this negativity about something that we have so much evidence for.
I have the exact same struggle. And clients will come in and I think you and I have talked about this. They'd rather give homemade turmeric paste or CBD or something. And it's not to say that there may be medicinal properties to that, but exactly what you said, we know that non-steroidals are going to be effective. There are certain dogs that can't take them. We know that. I mean, if their dogs have renal or kidney disease, if they have severe liver disease, they probably shouldn't take them. And that's when we're backed into a corner and have to pick something else. But when used appropriately under veterinary guidance at the right dose, they can be very effective and very safe. Yeah. Yeah. Absolutely.
I do think that we need to consider the dog. So, this is about the dog, and the dog is potentially really struggling at that point. If they finally broken through their coping mechanism, so they've been coping with pain for quite a while because they want to be your companion, they want to get on with life, they don't realize there's an alternative, so they don't kind of overtly show it, and they compensate and adjust and get on with life. When they finally do show us, it could be pretty bad. And I just think that people should realize it's a team approach, and hopefully over the next year, 5 years, 10 years, people will realize that you can have a holistic approach which incorporates medication. I get really frustrated that term in my mind is abused somewhat, in that holistic means treat the whole, it means treat the whole body, but it doesn't mean that you can't use things that you know are medicinally effective. You don't have to be on them for life. We're trying not to be, but let's try and get that dog out of pain as quickly as possible.
Yeah. No, I totally agree. And to your point that they hopefully aren't going to be on it for life. But one thing that we do know is that the longer that they're on it, within weeks to months and potentially even years, they get better and better and better. And so it's not a matter of just giving it here and there. I think when we're first starting a treatment program with a dog, they should probably be on it for at least a month. And I try and do a 3-month course before trying to cut back, because we know it's going to take, if we're working on weight loss, it's going to take that amount of time. If we're working on
I disappeared. I'm back.
That's right. Just saying, there are studies to show that the longer the dog is on a non-steroidal, their activity actually improves, you know, better and better and better at each time point that's managed.
Yeah.
So, yeah.
And that's true. And I think that's something that the veterinary profession who watch this, and therapists and vet nurses that are watching this, we need to stop being in fear of prescribing a chunky course. Okay. And I think there is a problem, and I was talking about it yesterday. When you have an owner that can't see that their dog is in pain, and you as a veterinary professional has just told them something that they've not seen, and they're probably taking time to catch up with you in this 10 to 15 minute, what my dog's been in pain for, I'm not sure. I came in with a wart.
Exactly.
You're now telling me my dog is in pain.
Yeah.
And then you prescribe them an anti-inflammatory, and the back of your brain is going, I bet your bottom dollar this one will get diarrhea. You know, I've dispensed it 250 times this month, and this one will get diarrhea. So you kind of go, oh, I'm just going to give a short course, just in case. And you're like, no. The side effect rate with non-steroidals is really, really very low, considering how much we use. We use it day in, day out. And us dispensing a 7-day course for a dog with significant arthritis is not doing anybody any favors whatsoever. The owner will have had 7 days, and that's their kind of expectation. That's their price point. That's their commitment. And when they come back and they haven't seen any change, they're not going to go there again. We've burnt that bridge. Whereas if we send them away saying this is 28 days minimum, more than likely 56, 72, and we're going to see a continual improvement over time. And we're going to actually really reassess this about 3 months. And we're going to see how you feel, objective changes, etc. And I think that's really important, because we're not giving the non-steroidals a chance by doing the 7-day thing. So in a way, it would be lovely if we can really kind of utilize something that we've got so much evidence about better. Now, for the public that are following this, the reason, and this is me being outlandish, what I'm about to say, drug companies really can't market themselves. They have to be very, very careful of who they advertise to. But it's very hard to defend themselves. So when you read lots and lots of magazine articles about the side effects of non-steroidal, you're not actually having a counter argument at all, because there's strict regulations about who they are allowed to advertise to. They're allowed to talk to us veterinary professionals, but they can't pipe up and talk to you guys. And I feel quite strongly as a veterinary profession, we should be able to talk about our experiences with these medications. And I wholeheartedly would put every single one of my pets on a non-steroidal if they're in pain, because I know how many times I've used them and how effective they've been and how few side effects I've really actually seen in my 17-year career. What do you think?
I totally agree. Totally agree. Yeah. I mean, I think it is a fear factor that people can latch onto. You know, I think we've talked about how good non-steroidals are. I think I feel remiss to just say that, you know, the big bad side effects happen when they don't get caught early. So what I tell clients is, if your dog goes off food, if they're not wanting to eat, that's the earliest sign that there may be something. And the most common side effect is going to be, you know, diarrhea or vomiting, stomach, you know, GI related. And so the earliest sign that you're concerned, talk to your veterinarian. Along those lines, stop the medication. Yeah. Stop the medication. For galliprant, that label is different now. It says, at least in the US, it says you don't have to stop it, but you should call. I think we still have to learn about what to do with that one, but at least
I was going to actually take your advice on that, because you've had galliprant in the US a lot longer than we've had in the UK. And it kind of goes against the grain for me as a vet to say, no, it's fine, just keep giving it through vomiting. I'm like,
I know. I have not seen much vomiting with it. I've actually seen more diarrhea, and by more, it's very infrequent. And if the dog has diarrhea, I'll have them stop, because that's not fun for anybody. With the vomiting, if I've had 1 or 2 out of hundreds of dogs I've treated that have vomited, and those dogs, they're still eating and they don't seem sick. I want to know, like, the clients call right away, and if they can't get a hold of me right away, I'm going to say, you know, stop it until we talk. But usually I'll have them keep giving it. We may play around with giving it with or without food, but that one I do have a little bit more comfort with the vomiting. Diarrhea,
Yeah.
I'll usually stop it and we may come back to it.
And this is kind of interesting, and I'm going to big Holly's army up a little bit, because I think sometimes we don't show how effective this community group is for not only supporting each other but also for us collecting data. And it's not a recognized way to collect data, because it's very anecdotal story. But in our anecdotal stories from the 2,500 members of Holly's army, we've had a fair few that have had the vomiting. We've had about 2 that have had the proper HGE disaster. And moving on, we've also had a number of people that have gone from being quite comfortable on a COX-2 specific, and they've gone, well, I know I'm in the long run on the non-steroidal, so I'm going to swap from a COX-2 onto the platelet, and they've seen a deterioration. People tend to talk about not seeing real signs of effect for 2 to 3 weeks. I don't know what you feel about effectiveness and timescale and stuff.
Yeah, I would say I would never expect galliprant to be more effective. When it first came out, I had 2 dogs that were needing something more. They were on a traditional COX-2, and we tried switching them to galliprant, like, let's see what happens, and they didn't do any better, so we switched them back. So I don't typically switch any patients to galliprant unless it's for a GI related issue or liver or kidney, or if they can't tolerate one of the other ones. So I'm using galliprant more as a first line rather than a switching to. But I think actually this whole discussion brings up a point that every dog has a different reaction to each non-steroidal, whether it's efficacy and safety. So one thing that I'm guilty of not doing well enough is if a dog's not doing as well as I'd like on carprofen, Rimadyl, I might add something else in rather than say, you know what, why don't we try Previcox and see if the dog does better on this one, or meloxicam. Because there is some old research from Daryl Millis that showed that every dog responds to at least one non-steroidal, and it's not always the same non-steroidal. So that's from an efficacy standpoint.
But I'm as fault as you as well.
Yeah.
And this is where science and art and experience come in. And I can remember I swapped a dog from meloxicam onto robenacoxib with the best intention, and the dog just couldn't stop sleeping. I was just like, that's not in the script, sorry.
Yeah.
And that owner was really disappointed me, because I'd come off something that they were plateaued but not improving. I'd introduced a more expensive drug. They'd had a period of inconvenience, and I was just like, sorry, that was not the plan. And then as you say, you kind of feel a little bit hesitant about doing it again. So we're all scientists, but we also do bring a little bit of experience and art into our work. And you've given me a slap. I'm gonna man up and start doing that again.
Well, I mean, the whole problem is the washout period, because you can't go from meloxicam to robenacoxib like in a day. So what do you do in between? And that's what we don't know. And that's I think why most people don't do the switch.
Yeah. So guys, any followers that are following this, and your owners, it's something. Do consider it. That there is a big family of drugs out there. They are all different. They are all under one umbrella with a similar kind of effect, but there are different drugs to try in that. And definitely, if your dog's reacted to one, try another. And if your dog's reacted to that, try one more at least. Though most of the specialists that I talk to, they're willing to give goes up till 4. They'll go 4 different ones. But communication with the owner to give them confidence that this is a accepted strategy.
Yeah.
Okay. So I don't know what's the time. How long have we been going now? We can go on for
yeah, I know. We're right at about an hour. Except I was late getting on, but
no.
Yeah.
Okay, so because I don't want to burn you out, and I don't want owners to not get the benefit, like they've done an hour and they're beginning to lose the concentration span. I would like all CAM followers that have found this useful to please say something underneath. I've seen there's been a few questions. I promise you we will answer them. But please tell us that this is useful, because, we put a lot of time and effort into this. What we're going to end on is 10 quick tips to help you. So this is very much owner focused. They're very short, sharp. tips of experience that we've had. And then I'm hoping that all your yays, this has been amazing, is going to get Kristin to come back and we can do more.
Anytime.
I just want her brain.
No, this is so much fun. I mean, I think we share the same brain, so I don't know that you need
I don't
mine.
think so. I don't think so. So, okay, you're going to start with top 10 tip. Okay, number 10.
I'm doing all 10?
No, you're going to do 10, I'll do 9. You do 8, I'll do 7.
Okay, got it. So tip number 1 is not to overfeed. Just don't overfeed.
Yeah, definitely. Yeah. So I'm going to do tip number 2. Please get independent advice about whether your dog is overweight or not. So I've just been in the pub and this lady has told me that her dog's arthritic and the dog was really overweight. And I'm like, that's the first thing we should be doing. Yeah. Please get somebody, not you, not a family member, a professional to critique your dog and go, this is the truth. Tip 3.
Yeah. Okay. Get in the habit of going for a walk with your dog every day. It is about a habit, and every day at the same time you go for a walk. Doesn't matter how long it is, whether it's raining outside or not, you go for a walk every day.
Cool. And I'm going to follow on with an adjunct to that, in that don't leave them to lay in. And this is something from personal experience, in that people kind of let their dog have a lay in like they're like a lazy teenager. Get them up first thing in the day and use some of your food. Get them out in the garden, get them out on the street, use a little bit of food coaching, because that initial movement of the day when they've been asleep and laying down for probably 6, 8, 10 hours is the hardest part of the day. So get them up, get them moving early, because you'll see a benefit for the rest of the day. Okay, number 5.
Okay, so sticking with the activity and food, I recommend feeding the amount based on what your dog's doing that day. So if you have a young dog that's active, they might need more to eat that day, and then they have a next day that they're not going to be very active. So for my dogs, I literally look down at them and I say, do you have a waist today? What are we going to do today? I'm going to give you this much food. Or, you know what, I've got a big day of working. You're not going to do much, so you get a little bit less today. So we don't eat the same amount of food every single day or the same number of calories. Our dogs don't need to either.
Yeah, and I agree with that. And there's a lot of people are very focused on routine and just doing the same thing, the same bowl, the same amount. I'm very fluid with Luna. I'm going to adjunct that, because I really feel that all of the major food manufacturers should be adding a interactive feeding toy to their packet of food for senior. And it doesn't matter what the condition. I believe that we are not using food to our best benefit, keep them moving, keep their brain active, etc. So don't be scared of these interactive feeding toys, but make sure that they're not frustrating. So please don't give them a toy that they're not going to have success, and success reasonably quite quickly. So don't put a load of kibble in a plastic bottle and they can't get it out, because that's just going to create a negative brain state, and that's not going to be good for pain management. So number 7.
Incorporate exercises, what we call therapeutic exercises, into daily routines. And so the most basic one is having your dog sit and stand. We call those kind of doggy squats. So when you go, if you take your dog for a walk, you come to a crosswalk, have them sit and then stand to go across. Have them sit before they get their food and then stand. And so just keeping those joints moving. This comes back to one of these misconceptions, is we actually need those joints to be moving and stay fluid, get that joint fluid moving around. Bring it full circle here. Have them do these exercises throughout the day.
Yeah, and it's free. It's absolutely free, and that drives us crazy, because quite a lot of things that are at your fingertips and people just aren't doing. Okay, number 8, my passion, flooring. Don't do these exercises on laminate flooring. I see it all the time. Sorry, brother, I'm going to say this. Alex, if you're watching this, I was watching his dog slipping on the floor at home again, and it sits there making me go, oh. And I think we're beginning to get more and more evidence that it isn't just about the dogs that have poor joints and poor mobility and poor strength. I think we should start thinking about it in our younger dogs, especially our growing dogs. Repetitive strains, they're going to be adding up to something.
Yeah, I couldn't agree more about flooring. Training or working with your dog to keep their nails trim. So especially those older dogs, especially if they're on laminate flooring, they can't get that grip with their nails. So if you can train your dog, I don't know if it's the same brand, but we have a Dremel tool where it's kind of like the nail file, just kind of working with your dog every week to make sure the nails stay nice and trim.
Perfect. And then I'm going to leave on the corker, because CAM and CARE have both been created because we know that there is not one size that fits all. There are no quick fixes. This is a long-term disease that owners need support and evidence-based advice. So if something sounds too good to be true, it is. If something says this is going to fix it all on by itself, it won't. If someone's spinning you 100% success rate, they're lying. And please become a bit more savvy about this, because we see it all the time where people have invested time, energy, and finances into modalities that haven't worked, interventions that haven't worked, and they come to us quite drained, exasperated, possibly frustrated, and we want to see you sooner. So please be savvy in quite a nasty world out there trying to sell you stuff. I think you're amazing.
I think you're amazing.
And so, if this has been useful, just say, and I'm sure Kristin will come back and join us.
Yeah.
And I'm going to also put your website, because at the moment, vets, you're allowing them to register free of charge, isn't it? So that they can see what you've been up to. So what we'll do is we'll get that registration below so that vets log in, become a member, see what Kristin's been up to, because it's fantastic. So we'll do that below, and then owners, please also look at Kristin's owner section, because I can't believe how much info is in there. It's insane. So please go and have a look at that. And I tell you what, we haven't done cubes. We're gonna have to do that next time.
Okay. I don't know what cubes are. Oh, my cubes, my cubes.
Your cube.
Oh, the quad.
Yeah,
we'll do that next time. Yeah.
We'll do quad. Sorry for calling it cube.
No, that's a good name for it.
Cool. Okay, so thanks guys, and we will see you later.
All right, thank you. Bye.
Bye.